This is a common localized upper respiratory infection, strep throat, characterized by inflamed tonsils and these distinct white exudate patches. While the throat infection is transient, it can lead to permanent cardiac damage in the form of scarring and stenosis of the mitral valve. This progression from a simple sore throat to heart failure is mediated by an aggressively misdirected host T-cell response. Acute rheumatic fever is a post-infectious autoimmune syndrome. The systemic damage occurs through the body's immune response, often weeks after the bacteria have been cleared from the respiratory tract. The driver behind this immune error is a phenomenon known as molecular mimicry. By tracing this mimicry from the microscopic level to its pathological targets, the seemingly random clinical manifestations defined by the Jones criteria become highly predictable. The exclusive microbiological trigger for this disease is group A beta hemolytic streptococcus, specifically Streptococcus pyogenes. Anatomy is a critical factor here. Only GAB-HS infections located in the pharynx trigger the rheumatic cascade. Streptococcal skin infections do not lead to this specific autoimmune complication. Bacterial anatomy reveals why. The outer capsule and underlying cell wall trick the immune system. The hyaluronic capsule is nearly identical to human joint and nervous tissues, causing antibodies to target the body. Similarly, the cell wall shares specific epitopes with cardiac valves. In susceptible hosts, this confusion is amplified by a decrease in regulatory T cells, allowing the immune response to escalate without its usual biological safeguards. Through molecular mimicry, the host's immune system effectively weaponizes itself against specific organs long after the original bacteria have been eradicated. Clinicians use the modified Jones criteria to organize these multi-system inflammatory responses. We start with the major criteria. Migratory polyarthritis is the most common manifestation, appearing in 80% of cases, typically targeting large joints. This arthritis leaves no deformity and responds rapidly to NSAIDs. Carditis is the most devastating manifestation, occurring in half of cases, often damaging the mitral valve. 10% experience Sydenham Chorea, exhibiting involuntary movements due to basal ganglia cross-reactivity. Dermatological signs include subcutaneous nodules, painless, pea-sized hard nodules that typically form on the extensor surfaces of the limbs and skull. There is also Erythema Marginatum, a rash characterized by transient pink macules with fading centers that create irregular rings across the trunk. These major criteria are the clinical evidence of the molecular cross-reactions occurring in the joints, heart, and brain. Minor criteria indicate systemic inflammation, but lack the diagnostic specificity of the major manifestations. This historical chart shows the prolonged fever that follows the initial sore throat. In low-risk populations, a temperature of 38.5 degrees Celsius or higher meets the diagnostic threshold for a minor criterion. Polyarthralgia, joint pain without swelling, is a minor criterion, excluded if polyarthritis is a major manifestation. Inflammation also affects the heart's electrical system, appearing as a prolonged PR interval on an ECG. Finally, lab tests will show elevated acute phase reactants, specifically an ESR above 60 mm per hour or a CRP of 3 or higher. While these minor symptoms prove the body is fighting a systemic inflammatory battle, they require the context of major criteria to confirm a diagnosis. Laboratory proof of a preceding strep infection is a diagnostic prerequisite. This is difficult because the infection resolves weeks before autoimmune symptoms begin, making throat cultures negative. Instead, physicians seek elevated anti-streptococcal antibodies. An ASO titer above 320 proves past infection. Echocardiography is also necessary to identify subclinical carditis, ensuring that silent valve damage is caught even if a physical exam is normal. Diagnosing this disease requires finding the immunological traces of a pathogen that has already left the patient's system. The final diagnostic equation for an initial episode requires either 2 major criteria or 1 major and 2 minor criteria, alongside evidence of a preceding strep infection. The clinical courses of these symptoms are very different. The arthritis and chorea are transient and resolve fully. The carditis, however, often causes permanent structural damage. Recurrent strep infections prime the immune response, leading to cumulative scarring known as rheumatic heart disease. Because of this risk, patients must adhere to long-term prophylactic antibiotic therapy, often penicillin, to prevent any future strep infections from re-triggering the autoimmune response. In acute rheumatic fever, the acute clinical manifestations are temporary, but the lifelong medical priority is the preservation of the heart's mechanical function.